wellness. You can be well. I think the reason why people run away from healthcare is because they believe it's something that is bad medicine. And my philosophy is that health is healthy, it's fun, you should be engaged, it's creative, you can really make a difference. And so that really is embodied in the song of Bob Marley. But then what you have to do then is measure every single thing. Okay, the slides aren't moving. I'll just very quickly, I really don't need the slides, right? So very quickly, what does joining mean? In the academic setting, joining means that you have public and private partnerships. You could have persons who are teaming, right? Teaming, building, collaborations. That's absolutely necessary for everything that we do. This slide really just means to say that, of course, Jamaica is the center of the universe. We are the sun. And the reason why that brain is moving forward is knowledge, right? There's a network. So you use that knowledge gained, and you create a network. Okay. I think the minister mentioned this before, and it's the sense that Center of Excellent Clinics help with health care development because they bring jobs, they bring indirect services. You have persons who then may need equipment, labs, etc. That's things that we as in the diaspora and locally can do. So if you have clinics, they actually do that piece, but it doesn't stop there. So it's direct services, it's also the additional things it brings, but then to think outside of Jamaica, bring that knowledge and export it, because if you bring it to a larger marketplace, you can do much better, I think. Very briefly, so global healthcare expenditures is $6.5 trillion, and of course the US consumes half of that. A lot of inefficiency, right? And the rate of inflation this year, the projected is about 8-9%, almost 3 times inflation. Is that a cause for an alarm? I think yes, because what it says is there's a lot of inefficiency in doing so. It won't go. All right, so why is there an opportunity for clinics? So I think about clinics as being part of the entire infrastructure of healthcare. If you are going to create a world-class healthcare hub, it has to be connected to every single thing that we do. So in Hartford, what we do essentially is we have an office of the University Office of Public Engagement. We liaise with them. There's also the Academic Center, where there are students and professionals who want experience in an urban setting. We recognize that the Office of Public Engagement have a lot of expertise because they're people who do research, and we say to them, look, fewer than 2% of any type of medical research, whether it's nutraceuticals, devices, fewer than 2% in the US has any person of color. And that really gives me chills because I'm thinking, well, if that's the case, you haven't tested that medication, that pill, that device on me, therefore, that's a problem. So I think the opportunity for clinic is exactly that. So if they're researchers, they can come in, do the help with the clinic, and they tend to bring dollars, expertise, and other resources. And again, when you do that, students, again, also need the experience. There usually is a specific curriculum that they have to meet. So what we do differently, actually, instead of what you do is, rather, folks come to us and say, we want to help you. And we say, yes, come to the party, but guess what? We want you to show up at 6 o'clock with only 2 pans of curry goat and it's not used. So we give you a work order. We look at all the information, and we say, we need you in December at 11 o'clock, show up with 2 pans of curry goat, a bottle of drink, don't bring anything else because it's going to be wasted, right? So that's kind of what we do. It's similar to what you do. So when we have a call from a medical mission and or someone else, we say, no, we will give you a work order. We look at every single piece of data. We know where the gaps are, and we tell you, this is because we've done the predictive modeling. We know in December we need a cardiologist, we need a GI person, we need this piece of equipment, and we hand it back to you. We love the fact that you've joined, But because we've asset mapped and we figure out who is out there and what they're doing, we actually tell you, no, we come to the party, but only come at 7 o'clock, only bring X, Y, Z, because if you come at 6, it's going to be wasted, right? So that's kind of the idea. So clinics of excellence, how do we get there? I think I kind of talked about this before. The Connecticut state budget is $18 billion. And the way the funding for the clinics are, it's kind of separate. So public health is really the administration that plans policies, strategies, get the stakeholders engaged. And the clinics actually are run by what's called federally qualified community health centers. In Connecticut, there's 17 of them. And why is that a good thing? Because they typically get funded by Medicaid. So Medicaid is the reimbursement process. In Connecticut, 50% of the funding of the cost comes from the federal government, 50% comes from the state. So they put 50 cents in, we put 50 cents in, and we support it that way. In Connecticut, it's 24% of the budget. That's just for the direct services. The DPH provides the administration, and that's less than 1%. In Hartford, pretty similar. The general fund, $613 million. Public health administration, $4.7 million, less than 1%. I have 2 minutes, but I think you get the idea. So what do I think that diaspora folks can do? Definitely join. I think you should join with the clinics. The other thing I think is an opportunity, if you guys think about it, is there are certainly local entities, nonprofit, international organizations that could do similar work like the FQHCs. So these are private, non-profit organizations that go in, they're assigned to a specific community to do direct services and to do everything, to link the care from end to end, but you don't stop there. You digitize it, you do meaning and measurement, you look at every single thing to understand what's going on, and then you hand it out. So my last thing I can tell you is essentially, so the 17 FQHCs, what they really do is there is a Community Health Center Association. The 17 health centers are members, and it serves basically as a business franchise. Why is that important? Because you really have 17 private entities coming in, different level of expertise. The association serves as the go-to central hub that provides strategy, policies, procedures, technical support. So if you come in and I say, I want to start Gary's FQHC, I go to Joan and she says, here's what you do. You don't have to do anything. It's all packaged. The only thing you have to figure out is, we'll get you the funding. If you need extra funding, you have to go to private funders. You have to go to philanthropy and to figure that out. But we kind of give you every single thing that you do. Everything gets into a database. And the thing that we also do is, we don't believe that we should give you the money and you haven't demonstrated that you've made a difference. So meaning and measurement means we look at the outcomes. We incent you by giving you a performance-based incentive. So we give you we give you the support, but then you have to come back a year later and say, you've made a difference. And I'm at the end of my slide. And I didn't get through them, but thank you. Of course, at the end, I'll take questions. That's it, just JAM. Thank you.
Okay. So, ladies and gentlemen, let's thank all our speakers in this first plenary session. Fit way off a fit, Dr. Tufton, Dr. Vincent Reed, and Dr. Gary Rule. So we have some microphones in the center aisle. So if you wrote on your question, you have a question, you could just
welcome to our live stream coverage of the plenary sessions at the Jamaica 55 Diaspora Conference. We're coming to you live from the Jamaica Conference Center, downtown Kingston. I'm Lorraine Mendez.
And I'm Theodore Henry. We just went through a couple of presentations. We will recap those, but we're now going into the interactive session where questions will be coming from the floor to the presenters. Thanks for watching. Please continue to share, especially on Twitter. It is hashtag Jamaica55 or hashtag Diaspora Conference.
Want to know how this can work and how this fits into your Center of Excellence model. I don't know if you could spend a few more minutes on that. And then we'll take questions from there. Yes, please. So for the questions, I'm going to ask you to introduce yourself also and to say where you're from.
Okay, thank you very much. On the issue of diagnostics and the Center of Excellence, the basic concept is that because we need or require specialist services given the health profile of the population, so you have more cancer cases, there are 4 areas in particular that we want to focus on: oncology, nephrology, kidney-related ailments, neurosurgery,
Neurology,
which is what Dr. Bruce is the specialist in,
cardiac,
and then cardiology, cardiac care. So those are the 4 areas that captures a fairly large percentage of the population. Now, in the area of oncology, the government had invested in these linear accelerators, 2, one in Montego Bay, one at St. Joseph's. The one in Montego Bay is at Cornwall Regional Hospital, which is scheduled to be operational in another month or so. The other one will be operational first quarter next year, maybe next April or thereabouts. The management of that facility or those facilities is key. These are expensive pieces of equipment. I think the total cost for both is about $14 million US. And we have been looking at entities, partnering with an entity to manage the facility under a public-private arrangement. So we have already put the infrastructure in place, meaning the equipment. It's now about how do you manage it for sustainability. There are all sorts of related matters to that, issues of insurance and charging those who have insurance, a portion being allocated to those who cannot afford. So that agreement has to be put together. And what we did, we appointed an enterprise team, for want of a better word, within the Ministry of Health, which includes the permanent secretary who happens to have been the head of Jamaica, so she understands the investment portfolio fairly well, to look at those proposals. So that's one example. The other, of course, Dr. Bruce, you're doing some work about UWI, which will see an expansion leading to greater levels of tertiary type care in certain specific specialization, as in the case of your area. And one of the things that we are exploring is how do we co-brand in order to provide those services? So how do we link with institutions abroad? So that would facilitate exchange of faculty, training of personnel, and also adding equipment or additional equipment to that process. So we are open to any idea that enhances the capacity to respond to the population, linking that idea to the public health system, but allowing a portion of that to be a private sector driven system. And it's just a matter of looking at the proposal and fleshing that out.
Thank you very much, Minister. So I'll take the first question. Could you introduce yourself?
Good morning. Thank you for this wonderful panel. I'm Dr. Carmen Nicholas, and I'm from South Florida. My specialty is I'm an applied developmental psychologist, particularly focusing on young children and their families.
Welcome.
Thank you. My question is for Dr. Tufton, and it relates to what is the landscape like for pediatric cases, pediatric health care. What are we seeing in terms of the healthcare needs, and how does the system now adequately support, especially children with critical care needs like cancer?
Okay. Thank you very much for your question. I'm going to take 3 more questions, and then I'll ask the panelists to respond. Then we'll take the next 4 after that. Please introduce yourself.
Good morning. I'm Claudette Powell, a registered nurse from New York. I chair the Jamaica Diaspora health sector in the Northeast, and I have been on this health trail since 2010, working on health projects, coming to Jamaica, liaising with the Ministry of Health. So I've been there, I've been in the trenches, and I've been watching the involvement of all the issues and some of the issues that are still on the table. But I'm also seeing progress. And I just want to ask Dr. Tufton, you know, the diaspora, as you said, is wide. And I'm just wondering, what system can you put in place to learn about the activities of the diaspora? Because some of what you discussed today, we have some current resolutions that I would like to share, but I know it cannot be done today. So I would ask you, what can you do for us to channel the information to you or your staff? I know we have Avigate Timberlake from the Director of the International Cooperation Unit, which came out of one of the diaspora conferences. So at today's conference, I'm asking you to take it a step further. I don't know if you'll be able to answer that later.
Thank you very much for your question. I'll take 2 questions from my left. Introduce yourself, please. Brief.
Thank you, Mr. Moderator. Good afternoon. Reverend
Morning.
Bennett, the Northeast Diaspora Movement. The question is for Minister Tufton. Minister Tufton, I watched with dismay a program on television here yesterday on renal failure. And I'm realizing that here in Jamaica, renal failure seems to be on the rise. And I'm wondering if we are looking into some research to find out what is going on, why we are having renal failure, particularly in children, which is usually adult. It is usually an adult disease. And well, I mean, I'm Reverend, what do I know about health? But I think there's a trend that is bothering, and I'm wondering if we're looking into doing some research as to why is it that Jamaica is seeing so much renal failure. I'm also concerned about the matter of treatment. I have my best friend we met each other when in grade 4. The guy had renal failure, and he told me that the treatment protocol here is supposed to be for three dialysis, or something like that, or 4, I don't remember. But what he says is that in Jamaica, he's now in the diaspora, but when he was in Jamaica, the protocol was way less than it should have been. And it was extremely expensive here.
So the question is on dialysis and the provision of dialysis care.
Mr. Moderator, just bear with me. Bear with me.
Sure.
The question, Mr. Minister, is, what can we do? Help us in the diaspora to understand the problem so that we can mobilize support for more dialysis centers in Jamaica, because we are realizing that not being dialyzed according to protocol, best practice, will lend to difficulty and death. So what can we do in the diaspora?
Understood. Thank you very much for your question. Next person, could you introduce yourself?
Thank you. Good morning. My name is Linda Hudson. I'm a barrister in the United Kingdom. Now, my little bit that I have to say is less of a question and more that of entreating the Minister of Health to do what, in my view, ought to be done. Now, I'll start by saying I'm from the parish of Hanover, and I'm a committed Hanoverian. Now, the background to this is that some members of the diaspora in the United Kingdom, they raised in the region of £40,000 to buy an ambulance for the Noel Holmes Hospital in Hanover. Now, these members of the diaspora are extremely careful. They followed all the procedures, contacted the Ministry of Health, and did everything according to the procedures. Now, that ambulance has been sitting on the wharf for 11 months now. Now, I've spoken to the lady, Mrs. Leslie, who's the sweetest lady you'll ever find. She's cooked drops and grater cake and gizzarda, and she sells everywhere, puts on all these dinner parties to raise money. Now, Dr. Tufton, this idea that the government is demanding under $3 million to release that ambulance that has the value of which is close to 10 million, is simply ludicrous in my view. And if the IMF is going to say that that is an important requirement, then it cannot be right. So that's what I entreat you to do.
Thank you very much for your question. I know the minister did speak to the protocol for donors and policies. What I'm going to do, I'm going to ask the minister to just answer the first 4 questions, and I'd also encourage anyone who is here from Canada and the UK would like to get some questions from you and your perspective. Minister, first 4 questions, sir.
I'm thinking that I might be better off standing up to respond. But
Yes, please do.
Okay. First of all, thank you very much for those questions. On the first issue related to pediatric care, we are now looking at overhauling the strategy for pediatric care. The main institution, of course, for pediatric care up to 12 years old is the Bustamante Hospital for Children. That facility requires expansion. In fact, ideally, we should, I'm told that another 150 beds would be ideally suited for that facility to deal with the demand on the system. It's not just catering to locals, it does cater also to the region, and they do a very good job. However, in some of the areas of specialization, we're somewhat limited, but building out that infrastructure as we speak. The key one being cardiac care. There is an ongoing effort which we are hoping to bring to conclusion during the course of this year, certainly by September, for expanded and new cardiac care facility that would see the capacity for surgeries in that age group being expanded from probably 50 or so a year to 250 a year. That is being done by Chain of Hope, Shaggy Foundation, a range of charitable organizations. They've had some difficulties because this has been in the work for some time, but I think we're getting there and we should see that on board. In addition to that, and as it relates now to other areas of specialization, the Chinese government has signed off on a gift working with the Ministry of Foreign Affairs for a children and adolescent facility, which will be built out in St. James on the compound of the Cornwall Regional Hospital. The delegation from China just went back to China. They were with us in the ministry, with the PS and others, working on the technical details of that facility. That facility is supposed to be a 220-bed hospital with a range of specialist services which will fill out the gaps that exist now in terms of certain areas of care for that age cohort. And we are hoping to break ground on that sometime next year, by the end of the first quarter of next year, give or take a few months. We have made significant progress. The value of that investment or gift is about $46 million US. So combined between Cornwall Regional and, between the facility in Western Jamaica and Bustamante, we would be in a position to double or a little beyond that our capacity to deal with children and adolescent care. Now, how does the diaspora fit into this, since I have to make it relevant to you? One of the things that we're going to have to do as we build a physical infrastructure is develop a personnel strategy for the people who are going to be in that hospital. We're going to need the specialists, the nurses, the doctors, the administrators. And frankly speaking, we don't have enough of them here in Jamaica. And so I'm putting out to all of us here, if there are persons or institutions that have an interest in returning home, who are specialists in that area of care, please contact us, because we are looking at a 2-year horizon to cut the ribbon on that facility, and that facility can't be open without the people to administer. The same applies for equipment. The Chinese will give us some equipment, but we're going to also have to purchase some. So my PS is on top of that, and if you send me the email or the contact information, we'll forward that. But we have a team headed by the CMO, Chief Medical Officer, who will be working on a parallel strategy to build out the personnel requirements, and I think it offers opportunities. On the second question of how does the diaspora assist? Well, I've just thrown out one offer. But more generally, what I have asked the Wellness Foundation to do is to develop a needs assessment of the public health portfolio. So that needs assessment will say what equipments are needed, what specialization are needed in personnel and otherwise, and that will be mounted on our website. And the intention is also to use our foreign affairs infrastructure across the globe so that they will have that data and tie that into the discussions that traditionally take place between the diaspora and the representatives who are in those markets under the auspices of the Ministry of Foreign Affairs and Foreign Trade. So we have recently added capacity to the Wellness Foundation. The head of that is Mr. Joe Shukir, who is a lawyer by training, and he is to pull that together, and hopefully that information will at least provide the diaspora with greater clarity as to what is required, and then your efforts can be channeled in that direction, hopefully for a more relevant response to the needs that are there. And the third question, which is renal failure. We have about 150,000 Jamaicans currently that require renal treatment, I am told. It is a high number, and it's a growing number, and it's linked to lifestyle, simply put. What we consume, you know, it adds to the risk profile, and parents will influence child, that sort of thing. So I'm not going to get into the medical explanation, even though that question was posed. The reality is we have that challenge, and it has to be dealt with. If you recall, in my presentation, I identified 4 areas of specialization that is required to treat with our health profile. And one is nephrology, which is the renal, the kidney dialysis, and so on. It is expensive to do dialysis. It's about $12,000 to $15,000 per treatment, Jamaican. And ideally, you need 3 treatments. So the average Jamaican can't afford $50,000 to get 3 ideal treatments per week. And so some do 1 or 2, which clearly facilitates their demise over time. The public health system does provide free renal care, but each of those hospitals that provide it, you have to be on a list because they can do so much and no more in a given day. So a hospital like Spanish Town may have a capacity because they have 4 machines and they treat 30 people a day. They can't do more than that. I'm just using a number. And that applies across the board. So frankly, you have to be on a waiting list to get into the public system unless we can expand that capacity. Otherwise, you go to a private facility and pay, and I just explained the cost. What we are trying to do is to lower the cost. Again, this is an ideal area for public-private arrangement. We are talking to a few investors who have expressed an interest. One out of India, where they seem to have some technology to support a low-cost administration of renal treatment. But we're open to suggestions, and in terms of donation and so on, that area is an area that requires attention. In addition to that, we have started discussion on live kidney transplant. Jamaica does about 5 or 6 each year, supported by a team out of the UK. I was in the UK about 5 months ago, and I met with that team. They actually established a kidney transplant program in Trinidad, where over the last couple of years, the Trinidadians have done over 100 transplants. A live transplant is simply this. You find somebody who is compatible, and they donate one of their kidneys to you. That, I think, we could get up and running. And part of the plan for the expansion of the Center of Excellence for St. Joseph's would be for oncology and nephrology. Included in that would be both kidney dialysis, but also live transplant. And we're working on that to try and make that a reality in terms of a response to that issue. On the issue of ambulance, I know it's very emotional and understandably so on that issue. The truth is that when that facility was shipped to Jamaica, the agreements, and the lady who spoke clearly knows, because she mentioned it, the requirements under the current IMF agreement in terms of gift and charity does not include motor vehicles. I have personally made appeal to the Ministry of Finance and spoken to my colleague, Minister Shaw, who has, since recently, we have decided to, he has indicated that he'll grant a waiver, a moratorium on the $39,000 US that is required to clear the vehicle, and allow us to budget to pay for it in the next financial year. This is the Ministry of Health. And that's the last option that I'm exploring to get that facility off. But frankly speaking, in the future, those who are making donations, which includes motor vehicles, will have to consider the clearing of it as they consider the procurement of that vehicle, because the rules have changed. Not me change the rules. The rules are based on the debt profile of the population and the IMF stipulation that we have to pay the debt and we mustn't give up revenue on certain things. I can't influence that beyond what is there. And I've explained to the donor 100 times why I can't call customs and tell them to clear the vehicle, because the rules doesn't allow it. So I have to deal with the portfolio ministry that is now saying they will give me a moratorium. So when the PS is projecting the next budget for April next year, I'm going to have to put $4 million in there to pay for this particular donation. But it's not something that we can do as a routine. Thank you.
Thank you very much. And I'm going to take 4 more questions. Gary, I'm going to ask you, one of your slides had something on telemedicine. I'm going to ask you to comment on the use of that. And also, Vincent, I want you to speak a little bit more about centralization and how we can use that within these specialist areas of excellence. So I'll get to you guys shortly. If I could just get back to the audience, we'll take 4 more very brief questions. And if there's anyone from the UK or Canada, we're particularly interested in hearing from you also. So I'll take on my right.
Good morning. My name is Marie Kellier. I am living in Los Angeles at the moment. I am the new alternate advisor board member for the West Midwest region, USA. My question is to Dr. Roll, and I am wondering, in the packaging that you mentioned in terms of creating these centers of excellence, if those packages could be made available to organizations who may be willing to not only adopt a clinic, but to also make it a business investment. There are many organizations who raise 50, 60, 70,000 US every year to come down to do missions. What if those dollars were invested in a clinic as an investment option, in addition to, as the minister suggests, adopting it, but making it an ongoing concern, a public-private partnership? If there could be a package that could be put together and presented. Also, if we could do some measure of asset mapping in terms of the organizations that are currently involved in these missions throughout the US and wherever else in the diaspora we come from, then that would be something that I think would be possible to go forward in terms of a long-term solution in addition to the proposal of these centers of excellence.
Thank you very much for your question, and I'll go to the left side. A brief question, please.
Well, Dr. Bruce, my name is Dr. Curtis Yates of Cornwall Regional Hospital. I'm a nephrologist, and I will just forego my question just to help answer and bring some more information to the crowd. Yes, Jamaica has 327 patients per million population that will develop end-stage renal failure every year. So our burden is high. Now, I'm part of the group that Dr. Tufton, the Honorable Minister, was speaking about, that partnered with a group from the UK that we have reintroduced transplantation in Jamaica. And one of our main reasons for that, Reverend Minister, is that we have realized that transplantation is actually, it's a bad word, but cheaper than dialysis. So we feel the best way to expand our program is via transplantation. So we could provide more room for people who might need hemodialysis and can't get transplantation, but at the same time reduce the cost of kidney replacement treatment. And yes, Reverend, there's research going on in Jamaica for the cause of renal failure. It's mainly because of hypertension and diabetes. Unfortunately, 25% of our adult population are hypertensive and 8% of our adult population are diabetic. So you can see where the burden comes from. So I won't ask a question anymore, just to say that this is information, and we applaud the minister for meeting our group in England who are helping us with transplantation. And the diaspora will help because we realize we can't do it without your help. Thank you.
Yeah, and thank you very much for that, Dr. Yates. And Curtis, we're really hoping that the minister will be able to visit the center that you trained at in the UK and to see more specific as we try to, again, re-expand the renal transplant program, which was actually quite active at KPH and the university not so long ago. So that will help to get some patients off dialysis. But again, we also have an initiative, Jamaica Moves, to make sure that we're trying to work on the non-communicable diseases, controlling diabetes and hypertension, which is one of the leading causes of kidney problems in the country. So I'll come back to my right question. Gary, I know you have something that you have to answer, plus the telemedicine.
Good morning.
Morning.
My name is Pearl Jarrett, and I am the CEO of the Jarrett Foundation in the UK.
Welcome.
Thank you. My question is for Minister Tufton. It's just simply, we're interested in new hospital builds, and we're interested in a PPP arrangement with you, and just what would be my first point of call to be able to facilitate that arrangement?
Okay, great. Thanks for that question. And I don't know if our permanent secretary has some experience with the DBJ and PPPs, if she'll want to comment along with the minister. Sir, I'll take your question on the left.
My name is Winston Miller. I'm from Markham, Ontario, Canada.
Welcome.
My question is for Minister Tufton. Minister Tufton, I thank you for acknowledging the importance of public health and health promotion. That indicates my interest and bias. I'd like to ask a question. How does the government ensure the intersection of the Ministry of Health with the other ministries and agencies that have an impact on the social determinants of health? And by that, I'm thinking about things like food security and income and housing and so on. And the reason for asking this, I think, Minister, as you're fully aware, these are issues which really predispose to the non-communicable diseases which you referred to.
Thank you very much for your question. And I'll come back to my right.
Good morning. This question is for Minister Tufton. My name is Judy Villeneuve. I'm from New York City. I'm the Director of Operational Policy and Research with the New York City Department of Education. And my interest really is with health and children. I had the opportunity to spearhead a breakfast program in New York City. And the connection between cognitive development, of course, and education is something that is especially interesting to me, and part of why I'm participating in the conference is I'm trying to start a nonprofit where I'm going to be able to donate food, organic food, as part of a STEM organization and STEM programs at different schools, specifically in Montego Bay, so that I can contribute in some substantive way. And through that project that I'm trying to work on, and having a full-time job and coming back and forth to Jamaica, it's been difficult to identify who it is you need to go to in order to be able to make things happen. And with the interest of STEM education in mind, I've partnered with an organization called the Regent Project. They have lightly used, very heavy-duty medical equipment that they had an interest in donating to Jamaica for the purpose of the fact that they have different hospitals that have bought new equipment, and they have resources and warehouses full of this equipment. And I've tried for about a year to find the right contact that we could connect with in order to bring this equipment into Jamaica. And it's very exciting to find out that you are developing clinics. I can only assume that this kind of equipment would be useful. So I'd like to be put in touch with who is the right contact, as well as to find out what is Jamaica doing to support the nutrition that is necessary for students in Jamaica to be able to get the full maximum potential from their learning.
Thank you very much. Thanks for that question. And we will have that contact for you. So I'll just take this last question since you're standing. Please introduce yourself, and then I'll get the panelists up.
Good morning. My name is Maxine Elliott. I am originally from the UK, but I'm currently residing in Atlanta, Georgia. I am a public health practitioner and director of health information technology with Omni Systems Inc., located in Virginia. My question this morning, I've been listening to a lot of valuable information about how Jamaica, the Ministry of Health, is seeking to grow and expand the current quality and provision of services in Jamaica. But my question is, what level, and this is directed to Dr. Tufton, what level of priority are you placing on developing in parallel the level technologies to create some of these efficiencies to assist in access to care, to track government spending around this public health services that Jamaica is very much involved in. Many of you may already be acquainted with the United States, and this gentleman here already spoke about the Medicaid program. Many of those programs have an integral arm that deals with the independent monitoring and controlling of spending, reimbursements, and just using that data. While it is a normal operational process for your providers to dump data in, but then having access to that data to be able to do effective asset allocation, resource allocation, and program planning. And I just wanted to know where in the mix of all of the discussion is your priority in finding those technological solutions?
Yeah. All right, thank you very much for that question. So I'm going to take it to the panelists in order. Gary, you got telemedicine and Center of Excellence, then centralization, Vincent, and then the minister will comment on the multiple agencies from Markham, Judy's, and the Jarrett Foundation. And the last question. Gary, your turn. Yes, please.
Okay, thanks for the questions. The first one is about telemedicine. We recognized by doing the health needs assessment that we really had a shortage of psychiatric providers, as well as GI specialists. And we recognized that specifically for psychiatry, most of the times that can be done through telemedicine, because what we usually need is diagnostic clarification and medication management. Most of the time the psychiatrist doesn't have to be physically in the room or to do that, but if they needed to, you can use, not saying that you should use these things, FaceTime, Skype, with the appropriate security to be sure that the information that is being exchanged is secured. So that's one thing that's being used. And there's evidence in the literature that's done. The University of Kentucky have done it, the University of Nevada has done that, many people have done that. If you also look at like United Healthcare and Health Anthem, they do the same thing. Evidence-based practice that some specialties can be done through telemedicine, provided you have the right infrastructure, the IT infrastructure, and the right controls. The second question really is about, and that's a business opportunity for the diaspora, right? So to help us help Jamaica develop that. The other question is around the clinics, right? So in Hartford, and my own philosophy as well is, I believe in Lean Six Sigma, or any other type of quality improvement system. And there should not be the way you drive quality and ensure that it's in place is the M of JAM, measurement and meaning, and that you pull that information through by continually looking, just like this young lady said. So we have people who want to come in, they want to start FQHC, and we say, great, but guess what? We don't believe that you have the right expertise. Come with your staff and the funds, and we will help you with everything, technical advice, the policies and programs, the practice management systems, the IT systems. We'll help you fund it or figure out how to get funding. And I believe that's an opportunity as well for the diaspora. So rather than folks coming in independently, I think the way you drive a world-class hub is to decrease variation. Evidence-based practice that we know, these programs work, these policies work, these providers work, and we know if you need 10 nurses to see 100 patients, we really come with a package and say, ideally, this is what you should do. But we don't stop there. We look, we set the management reports up for you, we tell you, we'll look at see what the gaps are and make recommendations in terms of how you should change. That's another business idea. So just like this young lady said, that's an opportunity for the diaspora, a business idea. One entity to do that piece, and rather than folks, 100 people coming in, starting their own thing, we say, no, the evidence says, because we've done it, because we've made mistakes, we know, ideally, this is what you need.
Okay.
And we funnel everyone through one chain.
Okay.
But with the way the FQHCs work in the US is, even when you do that independently, there's always oversight and supervision at the federal level. So you can't just do things randomly. So it would be similar. The Ministry of Health, you can come and do it, but we monitor every single thing that you do because we believe that with standardization and with policies, we reduce mistakes and variation.
Thank you very much. And I know Gary will be available to discuss it some more with you after the session. Vincent, centralization?
Regards to centralization, the issue is management and the most appropriate utilization of your resources. If you have limited resources and you have a group of hospitals, and each hospital is trying to be all things to all people, that is really the road to nowhere. If, for example, on a daily basis, for example, I treat a lot of breast cancers. That patient gets to the hospital 2 hours or 3 hours ahead of time. They get a magnetic bead placed at the site of the cancer or a needle in the breast, depending on the density of their breast. They get an injection in the breast so we can find a lymph node. And so there's a lot of work for what later on turns out to be a 90-minute operation. But all that prep work, all that expertise, and all of those things that needs to be done to lead to the experience of cure requires a certain centralization, a certain level of expertise that cannot be dispersed throughout smaller communities and dispersed randomly, because each municipality is trying to provide the same care. It's not possible with budgetary restraints and budgetary concerns. So the other thing that centralization would lead to is the centralization of your expertise. The opportunity for international fellowships, for example, at Stone Kettering. When I was a fellow there, we had a lot of international fellows from African countries, from all countries that were there for the express purpose of being an international fellow, to gather a certain level of expertise that they will take back to their country and develop programs. So I think that centralization works on many levels in regards to the facilities and the amenities and at the facilities, and also the individuals that are providing the kind of care.
Okay, thank you so very much. And again, the speakers will be available during the coffee break, which follows immediately. Minister, you have a suite of questions?
Okay, thank you very much. On the new hospital inquiry, I would recommend that if there is an interest, you speak with there's a booth outside, but the permanent secretary is right here. You want to just, right there, right? So as I said, we have a little committee that takes proposals and vets those proposals, and then depending on interest or suitability, then there's follow-up. There is a need for private care at the level of secondary and tertiary care. In fact, communities like the Portmore community, which has a heavy concentration of residential housing and business, we have always identified that area as an area that would benefit from some sort of private inpatient care facility. So I just give you that as one example. In other more creative thinking, there have been initiatives to add private wings to public institutions, and there are actually some hospitals that have private bed space. Of course, the most formalized one is UWI and Tony Thwaites, but there are others that are looking at it now. I know St. St. Anne's Bay, they have a small private wing, and it's something that we think is worth pursuing, and therefore one could look at that. The Bustamante Hospital for Children and the cardiac center that is being built, the next phase of that is going to have to be to build out a wing that will support those patients, those children that use that facility, and it looks like it is going to be a public-private arrangement. So I'm just giving you those as sort of examples of the possibilities, and we can follow. On the issue of health promotion, I am a big believer in health promotion, sir, because as the saying goes, prevention is better than cure. And the challenge with health promotion is that you don't see the benefits in the short term. You're trying to get people to change behavior, habits, culture, and that is not such an easy thing to do. It has to be a sustained program. The Jamaica Moves initiative is intended to start what we hope will continue over many years, well beyond my time, and perhaps yours, in order to try and change behavior. Trying to say to persons, you live better quality lives if you moderate your consumption in terms of portion size and what you consume, and you engage in that physical activity each day, 30 minutes a day. So we will continue on that, and the extent to which we can partner to support that, we are open. On the consumption side, because the Jamaica Moves focuses a lot on the physical activity, we have, sir, developed from a committee I named last year, a food task force committee, a report that assesses the impact of consumption on the population. And that task force has made some recommendation as it relates to what we eat, how we eat it, and the possibility of a regulatory framework to restrict the consumption habits of certain things. So in the school system, for example, I'm sure you would have seen in your jurisdiction the discussion around sugar and sugar intake and a sugar tax and what is allowed in schools, what isn't allowed. That debate has now started here, and we are being guided by that expert report headed by Professor Henry, who is based at the University of Technology. And this year, you are going to see a program rolled out using the recommendations from that report to start to sensitize the population around a more holistic approach to healthcare, focusing on the prevention side as opposed to the curative side. So that will capture a lot of the issues that you have mentioned. On the issue of somebody asked about organic foods and how do we get that in the system. You know, the holistic approach is multi-portfolio. The Ministry of Education is key to that, and my colleague and I are in dialogue around those issues. The Ministry of Agriculture is key to that. I was once the Minister of Agriculture, and we promoted eat what you grow and grow what you eat. So, you know, if you want to get very complex, you talk about the complex carbohydrates, the ground provisions are better, you know, fry versus non-fry and all that. All of that messaging is a function of how we collaborate with the cabinet, essentially. And the Food Task Force is helping, I think, to guide and will help to guide that process. The final one is the issue of technology. You're right, we have concluded that technology has to be a central part of enhancing the delivery of healthcare. And one of the things we did last year, we solicited and got from the Pan American Health Organization, which is the hemispheric body of WHO, their support through technical advice and coordination for a study to be done, a seminar to be conducted here in Jamaica for the region around health information systems and how we can create a technology platform that manages our patient files and the profile of our population, health profile. The spin-off from that are multiple. You heard about telemedicine and so on. Now, we have advanced that program over the last year significantly. We now have a report. There are two institutions or two programs being implemented now in Jamaica around health using technology to administer better care on the management of patient files. One is being done at UWI, where Dr. Bruce is very involved. That is being done by a private provider, and they are well advanced in putting that health information system in place, and it looks good so far. The other is using open source data to expand between two clinics, Darliston in Westmoreland and Santa Cruz in St. Elizabeth, and link that into Black River Hospital. That's in St. Elizabeth and Westmoreland side of the country. The work of PAHO has now resulted in a roadmap which we are now refining with a time schedule to start the process of institutionalizing that health information system that's going to be very necessary. We're talking to a bilateral partner to explore the possibility of them working with us, which will reduce our cost to implement that. But the objective is, over time, to move to using that technology for better health care. In that respect, the extent to which there are opportunities there, those who are in that field can look at it, and we are open to any suggestions or ideas. But we are committed to that. Linked into that, before I sit in 15 seconds, is a 10-year strategic plan that we're doing now, supported by the IDB, which is to look at where we need to go as a portfolio over the next 10, 20 years, and that is in progress. Linked to that is also a relook at the regional health authorities. You may recall that we sectionalized the healthcare provision along geographic zones back in 1987. 4 regional authorities. We have never really assessed comprehensively the effectiveness. There is anecdotal evidence, at least, to suggest that there are areas of inefficiencies and duplication which needs to be addressed. So PAHO is now doing an assessment of the regional health authorities with the intention of recommending changes which we believe will lead to some level of consolidation. I'll go no further than that. We'll await the study to look at that. And then the final thing we're doing is putting in place a national health insurance scheme. We are now out to tender to get consultants who will devise that scheme. Because frankly speaking, although we have a free healthcare policy, the reality is that healthcare is not free. And the question is, who pays for it? We are committed to universal access. So no one who can't afford should be denied. But I believe that we also have to prepare ourselves to contribute for when that day comes. And that's what health insurance is all about. We are committed to rolling that program out in the next financial year. It will be phased, but the consultants are going to be engaged in another month or so, and they will have 5 or 6 months to come back with a proposal, and PAHO is helping us with that. So we are, in a sense, developing a reform agenda for public health captured in all of these things that we're doing, and you will see some changes over the number of years to come. I want to commend the Diaspora in the UK. I must mention them, and they adopt a clinic program. They have actually gone well ahead of most. They have put out a publication that they have done, which I was in the UK some months ago, and they really put on a show. They have taken it very seriously. In fact, the High Commissioner, is he here? High Commissioner Ramakan has put together a committee, and they committed to adopting 55 clinics to recognize Jamaica 55. I think they're about 9 or 10. I want you to give them a round of applause, because that's... And it's a really nice publication, and they have a crowdfunding account. They've put all the technology and the platform in place. In fact, I've said to my guys back here, we probably need to learn a little from them, even though we conceptualize the idea. They are running even faster than us. So I want to say big up to the UK Diaspora, and looking forward to working with other groups. Thank you very much.
Thank you very much, Minister. So, ladies and gentlemen, we would say that that's been a fantastic morning. We have gone from health promotion and prevention through primary care, through use of technology and telemedicine, centralization. You've heard the plans for national health insurance. We with the strategic plan, which includes the pediatric hospitals, and also looking back at the health system and how we function. We have also seen that there are several opportunities for the Diaspora to partner, not only in primary care and promotion, but also in technology and diagnostics. Ideas, if you have them, on how to help with some of these specialist centers and centers of excellence. So we have a range of opportunities that I hope that you'll continue to discuss in the coffee break. I know the PS is here, and you had the contacts up early on the board. We also have a session on Wednesday at 1:45 where we'll continue this dialogue, and I hope that you'll continue to engage each other as we proceed the program. So all that's left for me to do this morning is to thank Minister Kamina Johnson-Smith and Minister Tufton for being here. I know you have cabinet today, and we really appreciate your time, and hope the Prime Minister will forgive us for keeping you the extra few minutes. I would also like to thank Chairman Earl Jarrett. He now has a bank to run. It's not just the Building Society, and we appreciate him being here this morning, and we hope he and his UK connections will support the Jamaica team in the UK. Vincent, it's always good to have you home. I know the District of Brandon Hill, and we appreciate your thoughts on surgical oncology and centralization of care. And Gary, we definitely would like to share what you've given us on the Center of Excellence and how to organize, but also how to do the asset mapping and to analyze what we're doing. So I want you to join with me to thank everyone on the panel this morning. I just took 10 minutes off your coffee break, and we invite you back soon.
We've just wrapped up the first plenary session here at the Jamaica 55 Diaspora Conference with the topic Fit You Off a Fit, Caring for Our Human Capital. And that was moderator Dr. Carl Bruce, Medical Chief of Staff, University Hospital of the West Indies. Presenters were Dr. Christopher Tufton, our own Minister of Health, Dr. Vincent Reed, who is a surgeon, researcher, and specialist in cancer diagnosis and treatment, Mercy Medical Center in the USA, and Dr. Gary Rule, Director of Public Health and Human Services, City of Hartford. Now, Dr. Tufton, he mentioned, well, many of the questions there focused on how Jamaicans in the diaspora can contribute to healthcare, and Dr. Tufton gave some options.
Yes. And he particularly stressed the importance. There are many people who want to give gifts. One of the questions was about an ambulance, and he particularly stressed the importance of contacting the ministry and allowing them to guide the donation of these gifts and donations, you know. And he also certainly reiterated very strongly the need for public-private partnership, especially in areas of dense human populations.
The minister also mentioned that he has commissioned a needs assessment, which would give members of the diaspora a greater idea in terms of what is required to support healthcare here, and that information, a list, will actually be published on the ministry's website, so they could actually view that to see, you know, what the needs are here at home.
And that's important, you know, because there was one of the questions about organic food. And as the former Minister of Agriculture, Dr. Christopher Tufton was saying how important that was. But, you know, it all has to be organized, and so that everything is done in order, and so the health system can go forward.
All right, so we're at the coffee break now, and in a few minutes we will begin the second plenary session right here in Conference Room 1, where we will look at the topic Jamaicans to the World, also focusing on building our human capital.
Definitely. And, you know, the focus on the human capital is not only on the education and the training programs, but also on the positive values and attitudes of the work, you know?
We are here with 2017 Governor General's Achievement Awards Diaspora recipient, Ms. Donika Aria Jones. And she is a public health and health equity specialist in Canada. Tell us about the work that you've been doing as a member of the diaspora in terms of supporting Jamaica.
It's actually been it's been a long time. So I think it started years ago, just tutoring children in the community, children at church, just recognizing that there are needs that students have and that they're not able to access, the services at school sometimes, or they just need additional support. So providing support in that area, also acting as a mentor for individuals. While I was at the University of Ottawa, I was working with a community-led, actually it was a university-led organization. And it was called the International House, and we used to do different activities just to promote, different aspects of our culture. And so we would do things like International Day, and I would put up, what do you call them? Presentations, just to promote, Jamaica and allow people to ask questions and to see different crafts and learn different things. I'm currently living in Nunavut, which is a territory in Canada, and I'm part of the Nunavut Black History Society. And it's a pan-Black organization, but we find different ways to include different aspects of our culture. So this year, one of the things that we did, we were asked to come in and speak to some of the students that are involved in a cooking club, and so we got to talk to them a little bit about history, incorporating a little bit of the Jamaican history, as well as do a food demonstration. So a colleague and I, who's also Jamaican, we did, we cooked with the kids, we made some jerk chicken and a little festival. So different things, that are available in the community, we find opportunity, or I've always tried to look for opportunities to promote Jamaica.
And Jamaican culture. What about promoting healthcare and good health practices? The minister mentioned that non-communicable diseases was one of our major problems here in Jamaica. Do you have any plans in terms of helping to promote greater healthcare practices?
Absolutely. I think I work in public health, so I'm definitely big on health promotion. And I think there is often, different components of health promotion that are lacking in public health. There are opportunities to partner. So I think it's very important for us to highlight some of these gaps and find ways to bridge these gaps so that we can promote good health or good health and well-being. And so I'm just looking for opportunities. Unfortunately, because of where I work up north. Most of the population that we work with is Indigenous. So a lot of the work that we do does revolve around health promotion and around public health. But I mean, personally, I'm always interested in, issues that affect the diaspora, that affect Jamaicans, that affect people of color. And so it's something that's also personal for me to advocate for things like screening and, just different health promotion, mental health and well-being and things like that.
And finally, what are your expectations for this conference?
To learn. It's a great opportunity to hear from other individuals and to share ideas and to share thoughts, but also to be able to share with others and share my thoughts and my opinions and, just learn from each other. It's a great opportunity to network and to meet new people. And so I'm open, and so, but I'm looking forward to it.
Thank you so much.
You're welcome.
Thank you for stopping by. That was Miss Donika Aria Jones, and she's a public health and health equity specialist in Canada. She's also a 2017 recipient of the Governor General's Achievement Awards Diaspora.
Okay, you tell me where I have to look. Yes. Sometimes I'm not doing that.
Mm-hmm. Here with me now is Claudette Powell, and she is one of our faithful donors to healthcare in Jamaica. I would say you mentioned that you have been working to support Jamaica's healthcare for the past 10 years.
Yes. I'd like for us to return to this room by 11:15. so we can try to catch up on the time. 11:15 is start time. Thank you. And I've been asked to remind the groups that later this afternoon, the Canadian delegation, US and UK will have separate meetings. That will be after the last session of Friday. Thank you.
Mrs. Claudette Powell, you are a nurse working in New York?
Yes, I'm a registered nurse, and you might have heard my introduction.
I did hear the passion in your voice in terms of supporting healthcare in Jamaica. Tell me some more about the work that you have been doing.
Yes, so, and I just want to add to that. I emphasize registered nurse because it's important to know that a nurse is quite important. But I also am an administrator for several years in regulatory affairs, compliance as a consultant. I do volunteer work. I'm part of the Jamaica Nurses Group of New York, which is the oldest Caribbean nursing organization in the United States. I'm also the past president of the Caribbean American Nurses Association. So with all that, I'm able to really galvanize persons, mainly nurses, and always thinking about Jamaica, the place that I was born, although I've spent longer years in the USA. So basically, I'm keeping up to date with the current issues in Jamaica, and I'm also just resourcing, trying to get help, coordinating conferences, forum, such as one that we had about a month ago in the United States. Was unable to talk about it here today, but I'm sure the opportunity will arise that I'll be able to share the good news that will be happening for Jamaica.
You can tell us here.
But basically, we had a
it.
forum where we brought the regional health directors from here and some education persons from the University of the West Indies to New York, paid all expense paid, and we wanted to look at the area of patient care, research, and information technology to help Jamaica. And we had 3 major breakthroughs with major institutions, the Mount Sinai Medical Center, Montefiore Medical Center, and Maimonides. And basically, we just had representatives from here meet with them, and by the end of that one-day meeting, we were ready to take it to the next level with meeting with ministry personnel.
So this would involve partnerships between our health facilities here
and there.
These that you mentioned.
Minister Tufton spoke about training. We had the director of nursing from the University of the West Indies, Dr. Weaver, was there, and he's so excited, elated about the plan that's going to be happening with a college called Lehman College. They're ready to get nurses and to also start an exchange program.
Wow.
Yes.
Amazing work, and
yes.
I know you will continue. Tell me about your expectations for this conference.
For this conference, you know, whenever you leave home, you're supposed to go back with something that you learn. And I've gotten some, it's different. One thing is different because I've been coming for 4 conferences. And the health session today, I'm trying to get used to how it was done. I'm going to be honest with you. I think the most positive part about what just took place was the Minister of Dr. Tufton's presentation.
We're actually going to have other ministers presenting at these plenary
Exactly,
sessions.
and I think they come with more information.
Yes, they will.
I'm
And
very
we
happy.
and
we had a chance to interact. So last conference or some of the other, we didn't have that much time. Today I was very pleased to see that audience participation. Still could always do it a little more time, but I'm not going to complain this time. It's more than we've had in previous conferences.
Thank you so much, Mrs. Claudette Powell, and
Yes.
please continue to support your homeland, Jamaica.
And I just want to tell you I know you have to go. You know, Thursday is the day of service.
Yes.
And I've coordinated a project in St. Thomas.
Nice.
Going down with a team of nurses.
Tell us a little bit about that?
Yes, going with a team of about 10 nurses. 3 of the nurses are trainers, professional trainers. They're going to Princess Margaret Hospital. 1 is going to do an in-service topic selected by the director of nurses to train the nurses. Right. And 2 will be doing basic life support training of hospital and community persons. The rest of us will be working alongside the staff at the Port Morant Health Center. You heard a lot about non-communicable diseases. The focus will be on that. We actually going to be doing some teaching the patients. And what's nice about that, we can identify with them. Sometimes not all the groups that come to Jamaica
can identify with the locals. All right.
All right. Yes, and thanks very much for the interview.
Thank you for coming.
Okay.
Welcome back, Theo.
Glad to be back.
So it was, we had a good discussion with 2 members of the diaspora who are contributing from their, let's call it their host country, they are contributing to Jamaica's development, particularly in healthcare and in terms of cultural promotion.
I see. I see. Well, we are now on the coffee break. They have asked us to reconvene at 11:15. It's a few minutes from now. As you can see behind us and around us and here, the atmosphere is alive. Right? The people are greeting, they're meeting, they're discussing the issues in further detail with the ministers. And also, I'm sure, Lorena, there are quite a few people outside in the marketplace.
At the marketplace, yes.
Right, you want to tell us a bit about that?
Well, there are a number of exhibitors at the marketplace, a number of small businesses, public